In this lecture, we are now going to look at physiology of the heart. We'll capture some basic concepts about heart physiology that I want you people to know. In terms of our outcome, we need to be aware of the histological features of cardiac muscle cells. We've just talked about that, so we will not look at that. If you've forgotten, you'll have to again check the lecture of anatomy of the heart. But in particular, we look at physiological features of cardiac muscle cells. Then we will revisit the concept of action potentials as seen in neurons. Sorry, as seen in the heart. The action potentials which are seen in the heart can be categorized into two. Those ones which are displayed by the pacemaker and those ones which are displayed by the rest of the cardiac muscle cells. We'll look at both of them. Then we will review the components of the cardiac conduction tissue, even though it's still fresh in our mind, most likely. The importance of reviewing it is so that we can put into perspective, therefore, the different waveforms of the ECG that we come across. So we will look at the different waveforms of the ECG. We'll translate how impulses move along the conduction tissue and translate that onto the ECG. That will be largely focusing on electrical events that take place in the heart. But after looking at the electrical events that take place in the heart, we'll now look at the mechanical events that take place in the heart. And that is what we are going to do when we talk about the cardiac cycle. After that, we'll look at the functional volumes of the heart. And we'll look at how the functions of the heart are regulated. As we agreed, we will not talk about the first one, so I've skipped histological features of cardiac muscle cells. But of course, you remember they are striated, mono or binucleated. They are short fibers. The nuclear is central, they are branched, and they have intercalated discs. Let's focus on the physiological features of cardiac muscle cells. Just like any muscle, cardiac muscle is excitable, which means that it's able to generate electrical impulses in form of action potential. It is also contractile, which means that it's able to shorten. Now, those are universal for all muscle cells. But there are some specific things we said that you need to check when you're describing physiological properties of muscle. And one of them is automaticity. On that note, we say that cardiac muscle is automatic. This is to mean that it can generate electrical impulses even without external stimulation. On second category, cardiac muscle is involuntary. And this is to mean that you don't have conscious control over cardiac muscle. Now, because you don't have conscious control over cardiac muscle, therefore cardiac muscle is controlled by the autonomic division of the nervous system. And on the third, we say that cardiac muscle is functionally syncytial. This is to mean that the muscles contract as one unit. They contract as one unit because they are interconnected by gap junctions. Those are the physiological properties of cardiac muscle. Now let's talk about the electrical events, the action potential and the molecular basis of each. So let me give you just a few minutes to remind yourself about that before we pick it up. I hope you've had time to review that. And so you have some concepts about an action potential and the molecular basis of each phase. Just to help you then capture what you're supposed to have done. Remember, there's a resting phase. And then we have the depolarization phase. Then there's the overshoot. Then the repolarization phase. And lastly, the hyperpolarization phase. The hyperpolarization phase is particularly unique to neurons because it's a period of sustained opening of the voltage-gated potassium channels beyond -70 millivolts. If you remember the physiology of an action potential in neurons, we said that the voltage-gated potassium channels close at -80. Yet the resting membrane potential of neurons is around -70. So there'll be sustained opening that is responsible for the hyperpolarization phase before the cell membrane potential, the resting potential is restored to -70. I've skipped intentionally the molecular events because I think that's what you've just reviewed. There's a question here that I want you to think through and maybe just have an answer in your mind. Let's look at this one again. So also have an answer in your mind. So let's follow on this one. The answers to your questions will come as we discuss this. I told you that there are two types of action potentials displayed by the heart muscle. There's what we call the pacemaker potentials, and there's what we call the non-pacemaker potentials. I want us to start with the non-pacemaker potentials. The non-pacemaker potentials are the kind of electrical disturbances which are displayed by the rest of the cardiac musculature apart from the sinoatrial node. They could be displayed by the atrial musculature or ventricular musculature apart from the sinoatrial node. Maybe the way the ventricular ones display them might be slightly different from the way the atrial display them, but the concepts will be the same, and so I'll discuss them together. The non-pacemaker potential has a resting membrane potential of -85 millivolts. And so that answers one of the questions that I posed to you. The action potential of the non-pacemaker is described to have 5 phases. Those phases are named phase 0, phase 1, 2, 3, and 4. a total of 5 phases. I want to take time slowly here and just describe the 5 phases of the non-pacemaker potential. I prefer starting with phase 4. This is phase 4, which is also here, phase 4. So from that graph, what is phase 4? Phase 4 is the resting membrane potential. We have said that resting membrane potential is at negative 85 millivolts. What are the molecular events that maintain the resting membrane potential at negative 85 millivolts? They are similar to the molecular events that you discussed that maintain the resting membrane potential of neurons. So remember, there are 4 factors that we talked about in earlier lectures. 1, potassium efflux is several times faster than sodium influx. 2, the effect of chloride influx. 3, the effect of sodium-potassium pump that pumps 3 sodium out for every 2 potassium in, therefore contributing to membrane polarity. The 4th factor was that we have more anions within the cell than outside. And so those 4 parameters maintain the resting membrane potential at a polarized state, which in neurons will be negative 85. Sorry, in neurons will be negative 70 millivolts, but in cardiac musculature, the non-pacemaker, it will be negative 85. Perhaps in skeletal muscles, negative 90. If the resting membrane potential is disturbed and the disturbance reaches a threshold, it can cause an action potential. When an action potential is generated, it will take us to phase 0. So let's now talk about phase 0. From this graph, we can see that phase 0 represents the depolarization phase of the action potential. So same molecular events that cause depolarization. Phase 0, the depolarization phase, is characterized by opening of voltage-gated sodium channels, and that causes massive sodium influx. So it's caused by sodium influx due to opening of voltage-gated sodium channels. So the membrane becomes depolarized to the level that we even reverse the polarity. When the membrane polarity is reversed, the sodium channels close. And that takes us to phase 1. So what is phase 1? Phase 1 is the overshoot phase. And the molecular event here is closure of voltage-gated sodium channels. So we no longer have sodium influx. Therefore, we cannot continue with the upstroke. After phase 1, now we go to phase 2. From this graph, we note that phase 2 is a unique phase. We didn't see it in neurons, but we are now seeing it in non-pacemaker potential. Phase 2 is called the plateau phase of the action potential. But what is it? It is a period of sustained membrane depolarization. What I mean is that the membrane is depolarized and it is remaining in the depolarized state for quite a while. Remember, here the membrane was polarized, the resting potential. Then depolarization took place. Right now, the membrane is depolarized. It is remaining in that depolarized state for some time. It's a period of sustained membrane depolarization. That depolarization phase can be long. And that is what makes the action potential of cardiac muscles to take long. Remember, in neurons, about 2 to 4 milliseconds, that's the duration of an action potential. In cardiac muscles, 1 to 2 milliseconds is the duration of an action potential. In non-pacemaker cardiac muscle, it can reach 300 milliseconds. Those are several times longer than if you compare with what we see in neurons and skeletal muscles. Why do we need that period? First of all, what causes that period? That period is caused by predominantly calcium influx, the influx of calcium ions. And that answers the second question that I asked you, which influx of which ions are responsible for depolarization. It is the influx of sodium and the influx of calcium. Why do cardiac muscles need this sustained period of depolarization? To answer that question, you need to remember something about physiology of muscle. That muscles are excitable, yes, they can generate action potentials. When they generate an action potential, or let me say, when muscles experience an action potential within them, they respond by contraction. That is what skeletal muscles do, smooth muscles do, even cardiac muscles do the same. Whenever there is depolarization, it will trigger the molecular events that lead to contractile response. So you need to remember that one. Then you need to remember something about the characteristics of an action potential. We talked about different characteristics of action potential. And one of them, we said, is that the action potential has a refractory period, a period within which it is difficult to initiate another action potential. It could be absolute refractory, which means it is impossible to initiate another action potential. And that referred to the period of depolarization, overshoot, and repolarization. Basically, when the membrane is polarized. And then there is the relative refractory period, which in neurons referred to the period of hyperpolarization, where you can initiate an action potential, but using a stronger stimulus. The point here is that if the membrane is in the depolarized state, then it is impossible to initiate another action potential on top. So if we are saying that the plateau phase is a period of sustained membrane depolarization, then we are saying that it is impossible to initiate another action potential during that period. So if you are saying that this plateau phase makes the action potential to last for 300 milliseconds, then it means that within those 300 milliseconds, you cannot initiate another action potential. Why is that important? In cardiac muscle, you want the muscle to experience a depolarization sequence and then respond by contraction. And you want that muscle to relax first before it can contract again. Remember, cardiac muscle is a pump. So it should contract, then allow time to relax before it can contract again, because it's a pump. It's not so like skeletal muscle where you can contract and sustain the contraction. Now, in skeletal muscle, because the action potentials are very short, it means that you can have very many action potentials within short periods of time. What is the implication? In skeletal muscle, you can have contractions on top of contractions. In simple terms, you can have sustained contraction in skeletal muscle, or what we call tetanus. Tetanic contractions are possible in skeletal muscle. You don't want tetanic contractions to occur in cardiac muscle. So because you don't want tetanic contractions to take place in cardiac muscle, you have to ensure that another action potential cannot be generated when one is going on, so that you cannot summate the contractions. That is why cardiac muscle has a plateau phase, to make the membrane be refractory to the generation of another action potential, so that you cannot have repeated contractions or other contraction on top of another contraction. You have to allow one contraction sequence to go to relaxation before another contraction can then be generated. That is the importance of the plateau phase. So both cardiac musculature, both atrial musculature as well as ventricular musculature have the plateau phase, although the duration and the gradient of the plateau phase may vary between atria and ventricles. The one I'm showing you right now is more of the one from a ventricle, but the same concepts will apply. The ones for the atria are slightly shorter and they slant down more. They have a steeper gradient than the ones for ventricular musculature, but the concepts remain the same. All right. After the plateau phase, we now go to phase 3. Phase 3 is the phase of membrane repolarization, similar to what we have in neurons. And remember, that one is caused by opening of voltage-gated potassium channels, therefore causing potassium efflux. And after that, we go to phase 4, where we started, the resting state. Also notice that cardiac musculature will not have the hyperpolarization phase, because the resting state is at -85, beyond the -80, where the voltage-gated potassium channels will actually close. So that's why it doesn't have the hyperpolarization phase. That is the pacemaker potential, and that's the graph. Now you need to know this very well, because if you're going to talk about drugs which are used in the treatment of arrhythmias, they'll be talking about phase 0 drugs, sodium channel blockers. Phase 2 drugs, calcium channel blockers. Phase 3 drugs, potassium channel blockers. So you need to know what is phase 0, what is phase 2, what is phase 3. And you need to know the molecular event in each phase, so that you're able to understand the mechanism of action of the anti-arrhythmic drugs. Let's now look at the pacemaker potential. These ones are easy. The pacemaker potentials refer to the potentials which are displayed by the sinoatrial node. Remember, it is the pacemaker. The unique thing about pacemaker potentials is that they don't have a stable resting membrane potential. And that is why I'm putting that term resting in quotes. They don't have a stable resting membrane potential. What happens to the resting membrane potential? The resting membrane potential is usually continuously depolarizing. The membrane is continuously depolarizing. So if you look at the cell membrane of the pacemaker cells against time, the cell membrane is continuously depolarizing. What happens when the depolarization reaches a threshold? An action potential will be generated. And so that's generated. Another resting membrane potential, which is unstable. If it reaches a threshold, an action potential will be generated. We can follow the red thing. Unstable resting membrane potential reaches a threshold, an action potential is generated again. And the story continues. So we realize that the pacemaker spontaneously generates action potentials when the threshold for membrane depolarization is reached. It spontaneously generates action potentials on its own. The other thing unique about it is that the pacemaker potential does not have the plateau phase. Therefore, those two things actually make the sinoatrial node to be the actual pacemaker. Because if it lacks plateau phase, it means that it can actually generate impulses faster than the other muscles which have a plateau phase. And that is why this is the pacemaker then. Usually the pacemaker will be influenced, therefore, by the autonomic nervous system. Sympathetic will increase the activity of the pacemaker, and parasympathetic will slow down the pacemaker. But even without sympathetic and parasympathetic, the pacemaker will still spontaneously generate impulses and actually in a regular rhythm. All right, so those are the pacemaker potentials. Take note that the pacemaker doesn't have a plateau phase and its resting state is unstable. Let's remind ourselves what we mentioned about the cardiac conduction tissue. Before that reminder, just a question to you to test whether you remember actually what we said in the first part of the lecture of anatomy of the heart. So again, reflect on it before we proceed. Let's see from this one, the accuracy of your answer. We say that the conduction tissue is unique in the sense that they are binucleated cells, they are less contractile, and they have more gap junctions. We say that the impulse is initiated from the sinoatrial node, then they move through the internodal. I told you there's some funny names of people. Sorry, this is the interatrial or the internodal pathways to the AV node, then through the bundle of His, to the bundle branches and the like. We use this particular image to give us that storyline of how impulses travel. And I told you the AV node is a site of conduction delay. So when impulses begin from the sinoatrial node, they go to the left atrium and also to the AV node. That is the interatrial pathway, and these are the internodal pathways, anterior, middle, and posterior to the AV node, which is a site of conduction delay. So you see now, those are the nodal or supranodal parts. Then now from there, the other parts are below the nodes. So only the bundle of His from that previous question. Only the bundle of his is infranodal. Told you bundle of his divides into two, the right and left bundle branch. The left one divides into left anterior and left posterior. Then from the bundle branches, we have the Purkinje fibers. This is the path followed by cardiac electrical impulse. But let's translate that information to the ECG and see what happens. This graph shows you, okay, this image shows you the velocity of impulses in each of the different parts. I really don't want you to cram the actual absolute number, but I want you to capture two things. That the AV node is the slowest site. So the site of conduction delay. You can imagine 5 centimeters per second. Slow. Compare that with the one of Purkinje fibers, which is the fastest. 4 meters per second. Very fast. I don't want you to remember the 4 or the 0.05 meters, but I want you to remember that Purkinje is fastest, and AV node slowest. If you've captured that, let's translate that to the ECG, and this will require your attention so that we grasp well. The ECG is a graphic representation of the cardiac, and I want you to add overall, of the overall cardiac electrical activity. Now, we may be aware how we connect the ECG leads, or maybe you're not aware, fine. This lecture will not teach us how we connect, but I just want to look at the waveforms of the ECG and what they mean. A typical waveform will look like this, with different names given to the waveforms. Let's look at it this way. We've said that there's a time that impulses begin at the sinoatrial node. When impulses are being generated at the sinoatrial node, on the ECG, we don't have an overall deflection, and especially on lead 2, we don't have an overall deflection. What we have is just a flat wave against time. So we don't give it a name. But impulses begin from the SA node and travel both to the left atrium and also to the AV node. When that happens, it means that there is some depolarization that occurs within the atrial chambers. Depolarization that occurs in the atrial chambers is shown on the ECG as the P wave. So P wave represents atrial depolarization. Once the impulses have reached the AV node, there is some delay there, as we agreed. During that delay, there is no overall deflection on the ECG. So again, we have a flat tracing against time. We call that period of flat tracing the PR interval. Anyway, in terms of graph and calculation, we usually start the PR interval from there rather than from here. So from there to there is a PR interval. But what does it really mean? The PR interval represents conduction through the AV node, which means it actually represents the period, the duration of AV nodal conduction delay. After the delay, impulses then move to the AV bundle and its branches. During that time, there is a Q wave generated. So Q wave represents conduction through the AV bundle and its branches, which means basically conduction within the interventricular septum when the interventricular septum is receiving that impulse. You might be wondering why the P wave is a positive wave and the Q wave is a negative wave. The answer is this. The way the ECG lead is being put, and especially for lead 2, the one I'm tracing, the neutral point is actually roughly from the from the right shoulder to the left lower limb, roughly along that line. Right shoulder to the left lower limb. So that becomes the neutral axis. Now, any deflection to the left will be a positive wave. And any deflection to the right will be a negative wave. So if the neutral point is here, from there to somewhere there, the overall movement of impulses from the sinoatrial node is leftward, as you can see. And that is why P wave is a positive wave. But the overall movement of impulses from the AV node down through the interventricular septum is rightward. And that is why the Q wave is a negative wave. After that, impulses go to the Purkinje fibers. Purkinje fibers are several, but remember the left ventricle has a thicker wall, and so it will have more of them, which means that the overall impulses in the Purkinje will be a leftward and massive for that matter. Conduction to the Purkinje fibers give us a very sharp R wave to the positive. After that, the rest of the ventricular musculature now receive. Now, the rest of the ventricular musculature, the impulses will be moving that way because look, from the left ventricle, because this is the one that takes overall, the impulses will move from this point that way. So it's moving towards the right, and that will give you another negative wave, which we call the S wave. The S wave represents depolarization of the rest of the ventricular musculature after the Purkinje fibers. Now, this period from there up to there is known as the QRS complex. So what does QRS complex represent? The QRS complex represents the ventricular phase of depolarization. When impulses begin here, we are now already in the ventricles. So it represents the ventricular phase of depolarization, QRS complex. And for normal ECG, you want each P wave to be followed by a QRS complex. That is what we call sinus rhythm. To mean that all the impulses generated by the sinoatrial node translate to the ventricles. And so following atrial contraction, the ventricles will also contract. Remember from the action potential curve of the non-pacemaker that there is a plateau phase. When the ventricles depolarize, therefore, they will have a period of sustained membrane depolarization corresponding with the plateau phase of the action potential. On the ECG, that is reflected as another flat wave. We call that the ST segment. So the ST segment represents the plateau phase of the ventricles. That period when the ventricular musculature is in a sustained period of depolarization. The aim is to ensure that now another action potential does not come to make it contract. Well, after that, the ventricles will then need to repolarize. The repolarization phase of the ventricles is marked by the T wave, which is generally a positive wave as well. So these are the waveforms of the ECG and what they actually mean. Remember, T wave is ventricular repolarization, phase 3. This shows you the waveforms and the descriptions. I want to give you a minute to ask yourself from this graph. So what will the QT interval actually mean? You have a minute for that. I have now made the minute to be over. Now we can proceed. So this is the common thing that you'll be seeing in the normal tracings. Each P wave should be followed by QRS complex, and that's what we call sinus rhythm. There's a lot of information you can gather from ECG tracing, including heart rate and whether the rhythm is regular or irregular. Well, this class will not look at the pathology of the ECG. All right, so let's look at the next thing, the mechanical events that take place in the heart. Again, I want to go through this a bit slow. It will take some time, but I want us to focus on it. The cardiac cycle. So before we talk about cardiac cycle, remember, cardiac cycle basically refers to the events that occur in the heart from the beginning of one heartbeat to the beginning of the next heartbeat. So that's one cycle. Remember that the cycle will be initiated by the sinoatrial node having undergone depolarization, and so an electrical sequence moves from the sinoatrial node to the rest of the heart. Usually, there's some terminologies we use. Systole will mean contraction and diastole will mean relaxation. Remember that the AV nodal delay, makes the atrial mechanical events to be ahead of the ventricular mechanical events. Now, we will talk about the cardiac cycle, and we'll talk about 6 phases of the cardiac cycle. Let's begin with the first phase. The first phase is what we call atrial systole, which means atrial contraction. Let's explain it this way. Sinoatrial node generate impulses, fine. So I'm starting with the electrical event so that we can understand the mechanical event. When sinoatrial node generate impulses, those impulses travel to the AV node and also to the left atrium. That means that the atrial chambers undergo depolarization. How will the atria respond to that depolarization? The atria will contract. So atrial systole is a period of atrial contraction following atrial depolarization. When the atria contract, the pressure in the atria will go higher compared to the pressures in the ventricles. What will be the result of that? Blood will move from the atria to the ventricles. So during atrial during atrial systole, the pressure in the atria increase because the atria have contracted, and so blood moved to the ventricles. Of course, movement of blood to the ventricles is through the atrioventricular valves. The atrioventricular valves are narrow. And so what happens is that if the atrioventricular valves are narrow, it means that blood is being pumped through a narrow opening, and that will cause some turbulence. The turbulence caused at that time gives us a sound. But that sound is not the lub or the dub that you could be thinking about. It is not the first or the second heart sound. It is the fourth heart sound. We call it S4. So take note, S4 is caused by turbulence during atrial systole. Turbulence through the atrioventricular valve when blood moves from the atria to the ventricles. Okay, once blood has filled the ventricles, now the ventricles need to initiate a contraction. And sure enough, they do initiate a contraction. Now let's explain it this way. Remember, impulses have moved from the SA node to the AV node and also to the left atrium. And that means that the two atria have undergone depolarization. We talked of AV nodal delay, which allow the atrial events to be ahead of the ventricular events. After that delay, impulses will then move to the AV bundle and its branches, and also to the Purkinje and the rest of the ventricular musculature. I'm talking about the QRS complex of the ECG. And in response to the QRS complex, the ventricular musculature undergo contraction. So this phase, which we are calling isovolumetric ventricular systole, is that period when the ventricle responds to that depolarization by contraction. I'm going to tell you why isovolumetric, but for now, let's understand that the ventricles begin to contract. When the ventricles begin to contract, the pressure within the ventricles would then increase, perhaps rise above the pressure within the atria. The result is that the atrioventricular valves will close. When the atrioventricular valves close, there'll be a heart sound that we hear. That heart sound that we hear when the AV valves close is what we call the first heart sound, the S1. So take note, if a valve is like this, if you can see my video, when the leaflets go away, you don't hear sound, but when the leaflets come together, you hear sound. The heart sounds are heard when the valves close. So they snap. That is what we'll call the sound, not when they open. The S1 is caused by closure of the atrioventricular valve. So either that or that, they happen at the same time. All right, when the AV valves close, something unique we can say at this time. Look at this image. The atrioventricular valves have just closed, and that has led to the generation of the first heart sound, S1. The pressure within the ventricles rose above the pressure within the atria, and that is what made the AV valves to close. However, the pressure in the ventricles is not yet higher compared to the pressure within the outflow tracts. In simple terms, I'm saying the semilunar valves have not yet opened. So you realize that we are in an interim period when the AV valves are closed and the semilunar valves are still closed. So it means that the blood volume within the ventricles is constant. And that is why we are calling it isovolumetric. So this period is called isovolumetric ventricular systole or isovolumetric ventricular contraction because the volume of blood within the ventricles is constant. All the valves are closed. It's an interim period. As the pressure within the ventricles increase because the ventricles are still contracting, of course, the pressure within the ventricles will eventually exceed the pressure within the outflow tract, either aorta or the pulmonary trunk. Remember, pulmonary trunk comes from the right ventricle and aorta from the left ventricle. When the pressure in the ventricles exceed the ones in the outflow tract, semilunar valves will open and that will make blood to pump out of the ventricles. And that takes us to the next phase, which we call ventricular ejection. So what is ventricular ejection? We explain it this way. The ventricles are still contracting, and so the pressure in the ventricles are increasing. When the pressure in the ventricles exceed the pressure in the outflow tract, semilunar valves open. Remember the demonstration I gave you? When semilunar valves open, don't expect a sound. If the semilunar valves open, blood will be ejected out of the ventricles into the outflow tract. And that is why you call it ventricular ejection. It may surprise you that that is the only time that blood actually leaves the heart chambers to go outside. In all the phases 5, 6 that we are going to describe, that is the only time that blood leaves the heart to go to the circulation. Apart from, okay, sorry about that. Generally, the blood will now be pumped from the ventricles to the outflow tract, but the heart itself will be receiving blood during the diastolic phase and not during the systolic phase of the ventricles. Because when the heart is contracting, because of that pressure, the coronary vasculatures are generally constricted. But when the ventricles are in diastole, at least that time, the coronary vasculatures are open and so blood can flow in. After ventricular ejection, what do we expect? We expect the ventricles to begin to relax. When they begin to relax, we go to the next phase, which we call isovolumetric ventricular relaxation or isovolumetric ventricular diastole. And we can explain it this way. When the ventricles begin to relax, the pressure within the ventricles decrease. When the pressure within the ventricles decrease, semilunar valves will close. The closure of the semilunar valves will cause a heart sound, and that's the second heart sound. Remember, first heart sound is a lub, second heart sound is a dub. So this is the dub. The second heart sound is caused by closure of the semilunar valves. It occurs during isovolumetric ventricular relaxation. Why are we calling this isovolumetric? All the valves are still closed. Look, the semilunar valves are just closed because the pressure in the ventricles are decreasing. So they have gone below the pressure in the outflow tract, but the pressure in the ventricles are still higher than the pressure in the atria. So the atrioventricular valves are still closed as well. All ventricles are closed. That is why we are calling this isovolumetric ventricular diastole. The blood volume within the ventricles is constant, but the ventricles are relaxing. As relaxation of the ventricles continue, the pressure in the ventricle is going to go significantly lower than that of the atria. And that will make the valves, the AV valves to open. And that will make blood to rush then from the atria to the ventricles in this phase that we're calling the phase of rapid ventricular filling. Note something here. The ventricles are filling not because the atria are contracting, but because the ventricles are relaxing. There's a pressure difference. That pressure difference is significant, and so it makes blood to rush to the ventricles. During that rush of blood in the ventricles will cause another turbulence at the AV valves. And that turbulence will give us a sound. That is what we call the third heart sound, S3. So S3 and S4 are caused by turbulence when blood moves from the atria to the ventricles through the AV valves. S1 and S2 are due to closure of the valves. Take note. Right, that is rapid ventricular filling. What is the end point to this? The end point to this is when the pressures in the ventricles will be near equilibrium to that of the atria. That is when now blood will no longer move to the ventricles, or at least not significant. And that will lead us to the last phase, which we call late diastole or diastasis, so to speak. During the late diastole phase, the atrial and ventricular pressures are near equilibrium. And because of that, there is minimal movement of blood from the atria to the ventricles. Remember, during that period, all the chambers of the heart are in relaxation. We call it the period of diastasis or late diastole. After that, the next event will be the atria beginning contraction, marking the beginning of the next cycle. That will make blood to move now from the atria again to the ventricles. And so you notice that ventricular filling is in phases. The early ventricular filling is caused by pressure difference. That's what we call rapid ventricular filling. The late ventricular filling is due to atrial systole. Both ventricular fillings will give you some heart sound. The early ventricular filling gives you S3, and late ventricular filling gives you S4. All right, those are the phases of the cardiac cycle. We can look at it this way in this image. So atrial systole, when atria contract, blood moves to the ventricles. We get the fourth heart sound. After blood has filled the ventricles begin to contract, making the atrioventricular valves to close. So you hear the first heart sound. That is the period of isovolumetric ventricular systole because all the valves are closed, so the blood volume is constant. As the pressure increases, the semilunar valves will open, making blood to move out in what we call ventricular ejection. At the end of full contraction, the ventricles will begin to relax and semilunar valves will close. And so we call that isovolumetric ventricular relaxation, during which we hear the second heart sound, S2. As the ventricles relax, the pressure here decreases, and so atrioventricular valves will open, making blood to move from the atria to the ventricle in what we call rapid ventricular filling, during which we hear S3. The end point is when the pressure in the two chambers have equalized. When the pressures equalize, we go to what we call late diastole. All the chambers are in relaxation. There is minimal movement of blood. That will be followed with the atria beginning to contract again in a new phase, during which we hear S4. All right, so those are the phases of the cardiac cycle. I don't know whether this will play for you, or rather whether you'll hear the sound, but let's try. So I want you to listen to the normal heart sounds there. If you have an earphone, to be better. Well, don't worry if you didn't hear, even me, I didn't hear. But at least we saw something. These are the semilunar valves, and these are the atrioventricular valves. So when they close, you hear a second heart sound. When these ones close, you hear the first heart sound. The sounds from those valves are best heard at particular sites. This is also based on the anatomic orientation of the vasculatures. This way, the sound from the pulmonary valve is best heard on the second intercostal space, left parasternal border. The sound from the aortic valve is best heard on the right intercostal space, on the second intercostal space, right parasternal border. The sound from the mitral valve is best heard at the cardiac apex, which in adults would be fifth intercostal space, left mid-clavicular line. Maybe in a child to be in the fourth space, mid-clavicular line. The sound from the atrioventricular valve, the right atrioventricular valve, tricuspid valve, is best heard around the third to the fourth space on the left. Great. We've looked at the mechanical events that take place in the heart. I want us to now look at functional volumes of the heart. The first functional volume of the heart that I want us to talk about is the stroke volume. Stroke volume refers to the volume of blood that is ejected from either ventricle in a single contraction. So when the ventricle contracts, some blood is pumped out. The volume of blood that's pumped out in a single contraction from either ventricle is what we call stroke volume. The stroke volume will be affected by a number of things. For example, the force at which the ventricles are contracting, we call that contractility. Or remember, we call that inotropy. Also, the volume of blood that is filling the ventricles. The volume of blood that's filling the ventricles is called the preload. We are going to talk about it. And that one is affected by the blood volume as well. Okay, the second thing we want to talk about is the preload. So basically, this is a volume of blood that's entering the chambers of the heart. It will be affected by a number of things. But the blood volume itself will affect it, but also there's some pathologies that will reduce the preload. For example, restrictive diseases of the myocardium, narrowing diseases of the valves, or incompetency of the valves, obstructions of the veins will all decrease the preload. The other term I want us to define is afterload. Afterload is a force against which the heart must contract to move blood into the circulation. If you look at it that way, then you realize that the afterload is a measure of vascular resistance. If the heart is struggling more, it means that the vessels are resisting more. And vascular resistance is regulated by the muscle tone of the blood vessels. That will tell us more about whether they're in vasoconstriction or vasodilation. Apart from that, the vascular resistance also dependent on the ability of the blood vessels to accommodate blood, or what we call vascular compliance. As you know, as we age, the blood vessels become stiffer and stiffer, and so they lose their compliance. Right, so we've defined stroke volume, we've defined preload, we've defined afterload. I want us now to define the heart rate. This refers to the number of beats per minute. You are aware that the normal heart rate is about 60 to 100 beats per minute. A beat is actually one single cycle. So the number of cycles in 1 minute is what you call a heart rate. If the heart rate is below 60, you call that bradycardia. And if it's above 100, you call that tachycardia in an adult. The other thing I want us to define is the end diastolic volume. This is the volume of blood within the ventricles after full relaxation. The volume of blood within either ventricle after full relaxation. Closer to that is the end systolic volume. End systolic volume is the volume of blood within either ventricle at the end of full contraction. The volume of blood within either ventricle at the end of systole. Now, having known what stroke volume is, end diastolic volume and end systolic volume are, you should now have some mathematical relationship in your mind between those three parameters. We can say that stroke volume is equals to end diastolic volume, EDV, minus end systolic volume, ESV. That is stroke volume, because it is the volume that was ejected in a single contraction. And so if you know that SV is equals to EDV minus ESV, you can still then calculate ESV if you're given those two, or you can calculate EDV if you're given those two. The other thing I want us to define is ejection fraction. Ejection fraction, now listen to it because I'll want you to know the mathematical relationship. Ejection fraction referred to the proportion of end diastolic volume that is pumped out in a single contraction expressed as a percentage. I'll repeat it. The proportion of EDV that is pumped out in a single contraction expressed as a percentage. if you put that in very simple terms, we are comparing the stroke volume with the end diastolic volume, but we want to put in a percentage. So we are saying it is mathematically, it is stroke volume over end diastolic volume times 100. That is ejection fraction. This is to tell you that indeed, when the heart contracts in systole, not everything within the ventricles will leave the heart. Some blood will still not leave the heart, not leave the ventricles. They'll be remaining there, and that's the ESV. There'll be something that goes. Usually about 60% is ejected. The normal ejection fraction is closer to 60%. Of course, it can be more or less depending on different scenarios. How about cardiac output? Cardiac output is the volume of blood pumped out of either ventricle in 1 minute. The volume of blood pumped out of either ventricle in 1 minute. So if you want to know the mathematical relationship, if you want to calculate cardiac output, we can say that cardiac output, CO, is equals to stroke volume, the volume pumped out in a single contraction, multiplied by heart rate, the number of contractions in 1 minute. So cardiac output is equal to stroke volume times heart rate. Lastly, so the normal cardiac output is about 5 liters of blood. If you work that out, I've told you that the normal cardiac output is about 5 liters of blood. And you know that, yes, the heart rate is about 60 to 100 with an average of 72. Then you can actually work out what's the normal stroke volume. And if you get the normal stroke volume, you can work out what's the normal end diastolic volume and what's the normal end systolic volume, because I told you ejection fraction is about 60%. Now let's define cardiac reserve. Cardiac reserve refers to the extra cardiac output during exercise. That extra cardiac output that you have when you're performing a physical activity is what we call the cardiac reserve. So for us to calculate it, we will have to calculate the cardiac output during exercise, then subtract the normal cardiac output. Then you'll get cardiac reserve. All right, so those are the functional volumes of the heart that I want you to talk about, or I want you to know. Let's finish this lecture by talking about the functional regulation of the heart, how the heart functions are regulated. So the heart function is regulated in 2 ways. We have intrinsic regulation and extrinsic regulation. Intrinsic regulation refers to the heart regulating itself, basically. And this is based on the automaticity of cardiac muscle cells. That the heart muscle is able to control its rhythm on its own. Remember, automaticity is the ability to function even without external stimulation. This is largely courtesy of the sinoatrial node, which is able to set the pace for the heart and so controlling the rest of the cardiac musculature. So even without external stimulation, we are saying that the heart can actually control itself. That is intrinsic regulation. Then we have extrinsic regulation. Extrinsic regulation refers to regulation by external factors. The external factors here would be either hormones, that's what we call endocrine regulation, or the nervous system, and that is what we call neuronal regulation. The hormones that are likely to have influence on the heart are the catecholamines, primarily the epinephrine, that is adrenaline. Remember, it comes from the adrenal medulla. The other catecholamines are norepinephrine and dopamine. Apart from catecholamines, even the thyroid hormones have an effect on the heart. That's why if a patient has hyperthyroidism, then even their heart rate would increase. How about neuronal regulation? The nervous system controls heart functions by the autonomic division of the nervous system. Remember that the heart is involuntary. So it's not under somatic regulation, but it's under autonomic regulation. Before we talk about autonomic regulation of the heart, I want to give you some, I think, 2 questions to just answer based on your knowledge of the autonomic nervous system and based on what we've talked about today. So that is the first question that I want you to reflect on. This is the second question I also want to think through. Again, take time and look at it. Okay, let's proceed this way. So autonomic regulation to the heart is via both sympathetic and parasympathetic nervous system. The parasympathetic innervation to the heart is via the vagus nerve, which is the 10th cranial nerve. Remember, we have preganglionic and postganglionic neurons. The postganglionic parasympathetic neurons release acetylcholine. So the neurons are cholinergic. Therefore, the effects on the heart, parasympathetic effects on the heart are cholinergic effects mediated by acetylcholine binding to the muscarinic receptors on the heart. What are the effects? It will give us negative chronotropy, which is a reduction in heart rate. Negative inotropy, which is reduction in contractility, the force of contraction. Negative dromotropy, which means reduction in conduction velocity. So this is the one that will actually increase the PR interval. If we reduce the heart rate and we reduce inotropy, which means we'll have reduced stroke volume, then definitely we will reduce cardiac output, because we said cardiac output is a function of heart rate and stroke volume. How about sympathetic? Sympathetic innervation is via, remember, sympathetic outflow is thoracolumbar. But the sympathetic nerves that go to the heart come from T1 to T5 of the spinal cord. The postganglionic sympathetic neurons release noradrenaline as a neurotransmitter. So these are adrenergic effects, and they bind onto the beta-1 receptors. The effects increase heart rate, increase contractility, increased conduction velocity. That is why now sympathetic will reduce the PR interval. If you increase the heart rate and increase inotropy, which means eventually you'll have increased stroke volume, then definitely increase cardiac output. But there's something else I want to add here. Sympathetic stimulation to the heart also causes coronary vasodilation, if you remember what we mentioned in our lecture on autonomic nervous system. Great. So that is it for that lecture on physiology of the heart. We'll stop there.